Basal ganglia. Gray matter at the base of cerebral hemisphere is basal ganglia. We have two thalami. Laterally, we have two lentiform nucleuses. Quadrate nucleus is making an arch from the thalami to lentiform nucleus. The outer part of lentiform nucleus is putamen, while medial to putamen is globus pallidus. Central part of this area is called internal capsule, from where many white fibers or axons are coming up and down. Lateral side of the lentiform nucleus is external capsule. Laterally from the external capsule, the gray matter is claustrum, then white matter is extreme capsule, and then gray matter called insulas. Beneath, we have two substantia nigra in midbrain. The outer part is very dense, called substantia nigra pars compacta. Anterior part of substantia nigra is less densely packed gray matter called substantia nigra pars reticularis. Amygdala is the tail tip of the quadrate nucleus. Traditional basal ganglion, lentiform with putamen and globus pallidus. Quadrate nucleus with amygdaloid body and colostrum. Clinical basal ganglion, lentiform with putamen and globus pallidus, quadrate nucleus, subthalamus, substantia nigra. In lentiform nucleus, globus pallidus is divided in two parts. Near putamen, it is called globus pallidus external, and the deepest part is called globus pallidus internal. Corpus striatum. This includes putamen, globus pallidus, and quadrate nucleus. Neostriatum or only striatum. This is quadrate with only putamen. Corticospinal fibers from the cerebral hemisphere go down all the way, cross, and control motor fiber of the lower part of the opposite side of the body. Corticonuclear fiber come from the cerebral hemisphere, go up till the upper body, cross, and control motor function of the upper body. Before we make a movement, cerebral cortex consult with basal ganglion. Decision goes back to cerebral cortex through thalamus, and then cerebral cortex sends order through motor fibers. Motor area consists of premotor area, supplementary motor area, and primary motor area, and functionality it is also associated with somatosensory primary area. Idea of the movement starts from the prefrontal cortex. It goes to pre and supplementary motor area, which consult with basal ganglia. Basal ganglia make a decision, pass it to thalamus, which will pass it to the motor area, and now the fiber will come down to execute it. When we want to move, corticostriatus fiber come down from the frontal cortex to striatum. Striatum, remember, it is quadrate plus putamen, and stimulate the neurons in striatum. From striatus, another nucleus will fire up and through the stridopallidus fiber send the information to internal globus pallidus, which is the deepest part. From internal globus pallidus, another nucleus will fire and pallidothalamic fibers are going to thalami now. From thalami, another nucleus will fire and thalamico-cortico fibers take the decision and loop back to frontal cortex. This is called direct pathway. From cortex, the neurons are releasing stimulatory neurotransmitters called glutamate. Fibers coming from and going to the cortex are called glutaminergic fibers. Glutamate receptors will create cation reflux on striatum neurons. Striatopallidus fibers or GABAergic neurons will secrete GABA, gamma aminobutyric acid, and substance P on the internal pallidus neuron. Pallidothalamic neurons are also GABAergic neurons. So that means it is glutaminergic, GABAergic, again glutaminergic. Okay, so what happens when we are resting? Global pallidus internal is constantly firing when we are resting. Fibers are releasing GABA on ventro-anterior nucleus, ventrolateral nucleus, and dorsomedial nucleus of the thalami. GABA is inhibitory. GABA receptors allow the chloride influx and potassium efflux. Loss of potassium makes neuron hyperpolarized. GABA release makes glutaminergic thalamocortic fibers inhibited. So what happens when we move? Corticostriatum fiber will release glutamate on striatum neurons. Glutamate will stimulate stridopallidus fibers and have them release GABA on internal pallidus neuron. This will inhibit the pallidothalamic pathway and thalamocortex fiber, and now the message can transmit from the cortex to muscles. Indirect pathway. Glutaminergic fibers from the cortex to striatum neurons, then GABAergic fiber go to external pallidus neuron. From there the GABAergic fiber will go to neuron of subthalamus. From here glutaminergic fiber will go to internal pallidus. From here the GABAergic fiber will go to thalamus, from where the glutaminergic fiber will go to the cortex. From substantia nigra part compacta, neuron release dopamine. These nigrostriatal fibers go up and release dopamine on both direct and indirect pathway of the neurons. Direct pathway will be stimulated because it has D1 receptors for dopamine, and indirect pathway will be inhibited because it has D2 receptors for the dopamine. From the cortex, corticonigral glutaminergic fiber come directly to substantia nigra to stimulate the dopamine neurons. Compacta reticularis of substantia nigra is just like globus pallidus internum. Cholinergic neurons secrete acetylcholine, are within striatum, and they work on direct and indirect pathway. Their function is opposite of dopamine. If motor movement is less, that means it is hypokinesia. If motor movement is more, then it means it's hyperkinesia. Dyskinesia means when we are resting, we are making involuntarily movements. In Parkinson's, direct pathway is affected and movement is slow, means hypokinesia. Then it also has rigidity and tremors. In Parkinson's, degeneration of nucleus of pars compacta of substantia nigra happens. Release of dopamine is less on D1 and D2 receptors, resulting into inhibition of both pathways. Person will have difficulty to start a movement, blinking, or even smiling. Fiber goes from the cortex to halfway down are called cortico-reticular fiber, and fiber goes from the reticular to the end is called corticospinal fiber, which determine the tone of the movement. When cortex activity is less, cortico-reticular fiber activity is less, and reticular spinofiber fire more, and the tone of the flexors and extensors is strong, and rigidity happens. Difficulty to flex or extend. It's called lead pipe rigidity. In normal life, there should be a balance between dopaminergic and cholinergic activity. When dopaminergic is less, cholinergic activity becomes more. We have reverberation circuits in lentiform, means when the vibration is going ahead, it is also coming back through the surrounding neurons to stimulate the initial neuron. Action potential is moving in a circle. These reverberating circuits become fast when more acetylcholine. flexors and extensors becomes fast moving, and it's called resting tremors. MPDP associated with Parkinsonism in young people who are heroin addict. This can degenerate their dopamine neurons. Dopamine receptors blockers. Antipsychotic drugs stop dopaminergic receptors and function as the dopamine neurons are not working, and patient will develop difficulty in initiating the movement and or tremors. All of the above conditions were because of hypokinesia or akinesia, and now hyperkinesia or dyskinesia. GABAergic neurons in direct pathway has substance P, while in indirect pathway has enkephalin. That means any disease which affects on one type of GABAergic neuron doesn't affect on the other type of GABAergic neuron. Huntington disease degenerate GABAergic neuron in indirect pathway yield into overfire to cortex, resulting into excessive involuntary movements. It is hyperkinesia or dyskinesia. There are 4 kinds of hyperkinesia caused by problems with indirect pathway. Number 1, chorea. Number 2, athetosis. Number 3, dystonias. Number 4, balismus or hemibalismus. Number 5, tardive dyskinesia, and number 6, Wilson disease. Chorea, Huntington disease, St. Vitus dance, or Sydenham chorea. In chorea, there are sudden involuntary movements of the limbs. It happens when the GABAergic neurons of putamen are damaged. We inherit it. On chromosome number 4, there is a Huntington gene, trinucleotide repeat CAG is amplified, producing a toxin protein which damages the GABAergic neurons as well as cholinergic neurons. Depression and dementia can also occur. Huntington disease gets worse as it passes the generations. St. Vitus dance is common in girls when they develop rheumatic fever. Choreas will go away with fever. Wilson disease in hereditary dysfunction of copper metabolism. Protein called ceruloplasmin level is less in the blood, and copper accumulates in liver and in cornea, which is known as Kaiser-Fleischer ring, and in chordate and lentiform nucleus, and damage them. It's also called hepatolenticular disease. Genetic disorder worsen by the time because of the chromosome number 13 gene. Athetosis, slow movement transform from one to another like Indian classical dance. It happens because of the indirect pathway damage. Dystonias, muscle contracting for a long period of time. Neck is bent and we call it torticollis. Truncal muscles are over-released. Balismus or hemibalismus, hemibalismus means half body, happens in subthalamus problems. Clinical feature will occur on the contralateral side of the body, hip and shoulder girdle movement in the morning. Tardive dyskinesias. People who take antipsychotic drug, dopamine receptor blocker, after some time the receptor will produce more receptors in the striatum. Lips, tongue and periorbital cavity abnormalities and movements like tongue is